Thanks to all the audience who follows our broadcast. We have the honor today of having Dr. Mark Hamilton. Dr. Hamilton is a professor of neurosurgery, Department of Clinical Neurosciences, University of Calgary, Director, Adult Hydrocephalus Program, Shared Adult Hydrocephalus Clinical Research Network, Vice Chair, Medical Advisory Board of the Hydrocephalus Association, President of the Hydrocephalus Society. Right now at the IWBNC, Dr. Hamilton is going to share a lecture on improving treatment outcomes in adult hydrocephalus patients. Please type write your questions on the Q&A panel. We will read them after the end of Dr. Hamilton's intervention. Welcome, Dr. Hamilton, and thank you. It's all yours.
Thank you. I'm extremely grateful to have this opportunity to present and participate in the 2021 IWBNC. I think adult hydrocephalus is an important and significant part of neurosurgery. So again, thank you very much. So we will begin with a real bit minimal, short overview of hydrocephalus, and we're going to be talking about adult hydrocephalus, not pediatric, and then spend most of the time talking about shunts in the context of one particular type of adult hydrocephalus. I think that it's important that we use a diagnosis of hydrocephalus. This is one that Hal Recate proposed a number of years ago. And it basically says that hydrocephalus is an active distension of the ventricular system of the brain, resulting from inadequate passage of cerebrospinal fluid from its point of production within the ventricles to its point of absorption in the systemic circulation. So I think that the key term here is active. So we have to determine how to define ventriculomegaly, and then to distinguish ventriculomegaly from actual active clinical hydrocephalus. We're not going to spend a lot of time doing this except we get to the iNPH population. For looking at imaging, whether it's CT or MRI scan, I think it's useful to pick at least one way to measure the ventricles that you can do very quickly. There are a number of these available. One of the more common ones is the Evans index. The Evans index is a simple measure of the bifrontal diameter compared to the maximal biparietal diameter from the inner table. That's a ratio. So the higher the ratio, the bigger the ventricles in relationship to the brain. So here's a patient with a ratio under 0.3, and 0.3 is often used as a cutoff, who may have mild ventriculomegaly, but we didn't think had actual active hydrocephalus. And then this is a patient with ventriculomegaly, and part of the problem there is determining whether they need to go on to a shunt, as this patient did, or whether they have ventriculomegaly unrelated to an active process. Another important concept in the adult world is that hydrocephalus is not one entity, and that the clinical characteristics and a lot of the pathophysiology is very, very different for different subgroups. I proposed this classification a number of years ago. It's a clinical or pragmatic classification, but it's very useful because it really describes what you see in a broad adult hydrocephalus practice. So are they the transitional patients? They were treated when a child, so they become adults, and they have a lot of the issues of shunt management that they had when they were children. There's a group called unrecognized congenital that has a lot of other terms, arrested, compensated, chronic, SHIMA, APUC, there's a LOVA. There's a huge number of different terms, all of them with different nuances. But basically, they weren't treated as a child. They have big ventricles, and they probably had them most of their life. Acquired hydrocephalus we're all familiar with, subarachnoid hemorrhage, trauma, infection, brain tumor, and then idiopathic normal pressure hydrocephalus. So as part of my background work, I helped establish a research network, a clinical research network called AHCRN. Now has 8 centers in 3 countries, 2 in Canada, 5 in the US, and 1 in the United Kingdom. And part of our goal is to characterize adult hydrocephalus and to begin to do clinical trials. And we'll sort of come full circle around to that. This was one of our early papers characterizing the patients with adult hydrocephalus. And although that was a little over 500 patients, we now have just under 2,000 patients in our registry. And if you look here again, there's the 4 groups: transitional, unrecognized congenital, acquired, and iNPH. And the percentages down here don't represent necessarily true epidemiology, and we'll come and just discuss that in a minute, but they do represent a very significant sampling across these multiple centers. So what is the incidence or prevalence of hydrocephalus in the adult population? This was a systematic review that we published in 2018, looking at all ages hydrocephalus. It was pretty comprehensive, and it also defined a couple of challenges that exist. For instance, you cannot talk about incidence of hydrocephalus other than with infants using birth registries. And you can get good data on this. But when you start looking at older populations, whether it's older children or adults or the elderly, it's extremely challenging because you're usually using surrogate measures such as shunt insertion. And that's not telling you the true incidence. To do that, you'd have to go in and sample or look at everybody in a population to understand what the denominator was. What it did show was that the incidence and prevalence were pretty similar. The prevalence in the elderly was about 175 to 400 per 100,000. So very common. I'll show you that in a minute. And young adult information, middle-aged adult, extremely difficult to get information because it's not well reported. If we focus on iNPH, it probably increases with age. So there's about 175 per 100,000 over the age of 65. The mean was about 400 per 100,000 over the age of 80. And some studies showed that it was higher than that, 5.9% in Drage's paper in 2014 in Sweden. If you want to put that in context, if you look at the Central Brain Tumor Registry of the United States data over a 5-year interval, primary brain tumor has a prevalence, so this is similar measures, of 48 per 100,000, GBM 9.2 per 100,000. So I want you to think about that, that adult hydrocephalus is much more prevalent than even primary brain tumor. This paper looked at just the prevalence in iNPH, and you can see they showed that over the age of 65 is about 3.7%. This was again from Sweden, and it increased again if you were greater than 80 years of age. So adult hydrocephalus is a common disorder. So I'm going to talk mostly about shunts, but I just want to make a pitch for the idea of endoscopic third ventriculostomy. Of these 4 subtypes, unrecognized chronic congenital patients, a huge proportion of this population has an obstructive component in their hydrocephalus and are good candidates to consider ETV. There are many patients with acquired hydrocephalus who are good candidates for ETV. And then transition patients coming in with shunt failure as adults should be looked at to see whether they're a candidate for ETV. We'll come to discuss iNPH. Most of the patients with iNPH are not candidates for ETV. So this is an example of an unrecognized congenital hydrocephalus patient, big head, big ventricles, aqueductal stenosis. And this is the kind of patient where a third ventriculostomy is a much better option than a shunt and really should be considered as first line for this group. There's good literature out there. This is one paper we published in 2016, looking at long-term follow-up of 163 adult patients. So I do about 25 to 30 ETVs a year for this population, and it's very useful and saves them from a shunt. And we also give them the information that even with treatment with an ETV, they need long-term follow-up. So this Kaplan-Meier curve shows 2 elements of the population. This is the people coming in, first-time presentation, the green line, with hydrocephalus treated with an ETV. This is the ETV survival. So it's well above 90% for the patients with a first-time ETV. The failure rate in people who have a failed shunt, so a transition population or acquired patient who had a shunt failure, is not as good, but those are pretty good numbers long-term. This is like more than 10 years out. We're still seeing good survival numbers for the ETV. We have additional information that I don't have time to share, but in our network, we've looked at the neuropsychology and gait outcomes in people having a primary ETV, and it can produce significant measurable effects on both cognition and gait. What have we learned about this unrecognized congenital hydrocephalus population? There's a couple things that we can't get into, but basically not everybody needs immediate treatment when you see them. So we need to do a lot more work on how to determine who's the best candidate for treatment. But if you're going to treat ETV as effective and safe in the vast majority of these patients, this is a very old a picture here of an endoscopic procedure using cystoscopes. The modern procedure is much more eloquent and extremely safe. So we're going to spend most of our time talking about iNPH, or idiopathic normal pressure hydrocephalus. We'll focus on shunt treatment throughout this. And this gives us an example not only to look just at iNPH, but also look at issues related to improving shunt treatment outcomes. So what is iNPH? Well, this seminal paper from Solomon Hakim back in 1965 in the New England Journal of Medicine represents his thesis work looking at hydrocephalus and identifying patients with what was defined as normal pressure. And whether it's truly normal or not is not the something that is really relevant. It's identifying a group of people with, people who didn't have super high pressures or high pressures, and they were treatable. They defined a triad. There are three components. There's a gait or balance disorder. I think that people sometimes get stuck in a very rigid description of this, and it's much more fluid and much more broad. Cognitive impairment or dementia at the endpoints, and urinary frequency and urgency, which occurs long before incontinence occurs in most patients. And while these are non-specific, these symptoms improve with shunt treatment. So what happened after 1965? This was nicely summed up by Mike Williams, a neurologist from Seattle. There was this initial exuberance, which is probably irrational. Everybody got treated, poor indications, poor guidelines. The results were catastrophic. And this generated a lot of skepticism, which I'll come to in a minute. This is a meta-analysis published in 2001 by Hebe and Cusimano in neurosurgery. And what it was looking at was what had happened up to that point. And what was happening up to that point with treatment was that only a small number of patients had temporary improvement, very few had prolonged improvement, and complication rates were exquisitely high. You look at here, the range 5 to 100%. So I think there's been an era of research, and there's been a renaissance. There's a lot of centers doing very systematic work, and I'll go through those methods. However, there still is skepticism in the community. This was an editorial published by Dr. Saper, the editor-in-chief of Annals of Neurology. And it was a response to AAN guidelines that were published. And he called for a moratorium on shunting procedures for iNPH. And it was this lack of a placebo-controlled trial to deal with proving that this disorder existed. And that's a challenge in the community. There are still lots of neurologists and neurosurgeons and geriatricians who don't think that this is a real disorder. I'm going to show you that I think it is. I still think there is a significant responsibility, and we're doing things to deal with this, but there's a significant responsibility to prove that this is a treatable disorder, and then to reinforce the need for a systematic approach to assessing and sorting out these patients. So we can look at it along these lines. So what are your concerns, or what concerns you with a possible iNPH diagnosis? So when I talk to neurologists, neurosurgeons, geriatricians, there are three main sort of issues that come up individually or all together. So what's the barrier? And that's one way you can think of this wall here. So selection process, the consideration that selection process or diagnosis is poor. 2, treatment risks are high, and 3, treatment outcomes are poor. And I'm going to show you that all three of these, while relevant, are mitigatable and wrong. So let's take the first one. There's no good way to diagnose iNPH. And refer to this as idiopathic normal pressure hydrocephalus because some people use secondary hydrocephalus, and it is really not a disorder that is any way pathophysiologically related to iNPH. It is a clinical phenotype. And so we're talking about the elderly patient over the age of 60 with iNPH. And so this idea that there's no good selection process. Well, first you have to deal with the differential diagnosis. You'd be crazy if you start shunting people who have clear-cut Alzheimer's disease or frontotemporal dementia. You have to have a careful process to look out and select patients. That just makes common sense. And there are guidelines. So this is the international guidelines. These have been available since 2005. So that's over 16 years. And what the guidelines show, if you look over here, the degree of certainty of improvement, if one just uses a clinical exam and an imaging, so you have an Evans index that I talked about greater than 0.3, they have the triad, your chances of successfully picking people are about 50%. That's pretty bad. So that means a lot of people are going to get shunted without a good result. And then do you chase the patient or do you chase the shunt? In other words, you're trying to figure out whether your shunt's not working. So it ends up with a long downstream effect. However, if you do things like CSF testing, so this is the large volume TAP. In Europe, there's a lot of CSF dynamic testing. And in North America and in Europe, there's a lot of CSF drainage, external drainage testing. That probability of picking patients who will be successfully treated with a shunt increases dramatically. And it's, even though it says about 80% here, I think these numbers are much higher as we've gone from 2005 to 2021. There are 3 versions of guidelines in the Japanese Neurosurgical Society. They use similar sort of methodology, but it's becoming more nuanced as we identify more radiological features. There are now multiple studies. There's 2005 Williams, Marmero 2005 Williams, and I'll show you some local data from Calgary that show up to 90% of patients selected on the basis of CSF drainage demonstrate similar improvement after a shunt. So I tell patients when we're doing a lumbar drain that this mimics a shunt. If they get a response, we can almost always reproduce that with shunt treatment. And it also opens your eyes up to this being not just a bad choice of an operation for a patient, but it's probably a shunt-related problem and a shunt function problem. So you focus on that rather than that you pick the wrong patient. We do desperately need non-invasive biomarkers to demonstrate or identify treatment-responsive patients. We're not going to get into that today because that's a talk in itself and very, very important down the road. So second concern, shunt treatment risk is high. So let's just go a quick overview of shunts. It's been the mainstay of hydrocephalus. The goal is simply diverting CSF to another body cavity. And just to reiterate, for iNPH, endoscopic tracheostomy has a very limited role in the elderly patient. So the exception to this is the patients who have clear-cut obstructive hydrocephalus picked up at a later age, and you need very high-resolution imaging with either CIS or Fiesta, thin-cut sagittal imaging looking for aqueductal webs, webs in the foramen magendae or fourth ventricle. And you can find these patients, but on the whole, one should consider that iNPH, idiopathic neuropathic hydrocephalus, is a disease only treatable with a shunt. There are 3 types of shunts: VP, VA, LP. These are the common ones. There are other variations, of course, such as ventricular pleural, but this is really the majority of shunts used. This cartoon just illustrates a VP shunt coming down to the belly and a VA shunt being inserted in the neck. Now, just very briefly mention VA shunts at a later point, but they end up usually not in the right atrium, but we have some experience using a technique where we can set them right at the superior vena cava atrial junction. There's no evidence that any of these shunts are better than another. VP shunts are most common in the Americas and in Europe. LP shunts are slightly more common in Asia. Each of them has their own pluses and negatives, but there really has been no real good head-to-head study comparing them. So our technology and our techniques have improved. This is 50 years ago with a Rickham reservoir, a lot of metal, bulky, thick, stiff catheters. Things have improved a lot, but this paper illustrates that while things have improved technically, there are still some challenges in this population. So this is a paper from Joe Pyatt that was published just in the past year. And they used data from 2015 from a nationwide readmission database in the United States. This paper is important for 2 reasons. So one is that in that year, they identified almost 50,000 index admissions for hydrocephalus, and the vast majority were adults. So while we, again, still in many places consider hydrocephalus to be a pediatric disease, it is predominantly an adult disease. Pediatric hydrocephalus is often focused in children's hospitals in many places, especially in North America, however, and in Europe. However, in adults and elders, it's often a bit more diffuse, and there aren't that many primary centers. So, but in the United States, this is a really big population that needs to be looked at. equally important, the outcomes. So this is a Kaplan-Meier curve for readmission, for shunt revision. The outcomes are terrible. This is 100 days. We're down here almost 50% for children, for elders, for adults, and for infants. The worst outcomes are infants, but people tend to think that their adult population, they do well and they don't have a high shunt failure rate. And when you really look at numbers from a big database, that does not hold up. There's a lot of shunt failure that occurs in the adult population. So I'm going to put this in perspective and then come back to the same slide a little later. First of all, I think shunts are effective. I think we all know that. That's why we use them. They can malfunction, but can be fixed, and effectiveness can be recovered. That's why we do shunt revisions. And most shunt complications are minor and not life-threatening, but there's still considerable room for improvement. This is a quote from Mark Twain, and I think this summarizes shunt failure and shunt surgery. It ain't what you don't know that gets you into trouble, it's what you know for sure that just ain't so. So I think there are a lot of preset ideas about shunts and shunt surgery that need to be reevaluated. It's often perceived as a simple operation. It's sometimes described as the operation that you get the junior people or the residents to do. And there's not a lot of changes in the basics of the operation over the past 40 to 50 years. There have been changes in some of the materials, in some of the valves, but we're not talking about significant evolutionary changes. We're talking about basically tweaking that has improved some things. With the exception of programmable valves, which moved us up a notch, I think we haven't moved a long way forward since then. Again, another quote that I like because it summarizes shunt surgery. For insanity from Albert Einstein's doing the same thing over and over again, expecting different results. So if it didn't work last time, let's just revise that shunt again, and let's revise it again and again and again. And you've got to start thinking about why are you revising it? What is going wrong? Can I try a different approach? So why do shunts fail? Infection is one aspect. Actual failure of the ventricular catheter, the peritoneal catheter, the valve could be from fracture or from obstruction, blockage, and then shunt overdrainage. And we'll spend some time talking about all of these and a little bit of time about shunt overdrainage. So in Calgary, and this is from the results from a paper that's in Press and Journal of Neurosurgery, I undertook a quality improvement project. This was a 7-year project where we had prospectively collected data to document the outcomes with regard to shunt failure in a population of new shunt insertions. And we called it the Shunt Outcomes Quality Improvement Study. We used a number of things. One was a bundle of procedures to reduce infection. You may or may not be familiar with the Hydrocephalus clinical research work. They used a bundle, and John Kessel reported this back in 2011 and then again in 2016. Significantly reduced shunt infection rates in children by bundling together a number of commonly things that are done in the OR and demonstrating compliance with these procedures, reduced infection rates. So we used a bundle to change practice. The bundle was not just for shunt infection, but also involved a number of other elements of the shunt procedure. And this is just a review down here looking at the effects of care bundles on patient outcomes that provides additional information on this. So a lot of this is quality improvement methodology. It doesn't require doing a randomized trial. You can do this by collecting good information, prospective information, consecutive information on patients. So this was the shunt infection reduction bundle. So there are 4 aspects: preoperative optimization, so avoiding hypothermia, hyperglycemia, administering antibiotics at least 30 minutes prior to the first skin incision, reduce the operating room traffic. I think a very important part is if you're still using betadine, providine, switch to an alcohol-based chlorhexidine solution. This is much more efficacious. Make sure that it dries. I watched a lot of people put betadine on skin and they're basically draping right afterwards while everything's still wet. We use Ioban to help secure the drapes, and it also keeps people's contact with the skin down to a minimum. We double glove everybody. Everybody has to go through a full hand scrub, and we change the other layers of the gloves after we drape. I think that's the most likely time to which you're going to cause contamination of your gloves. We double glove because people get holes in gloves, and that reduces the risk of that. We only open the shunt when we're about to use it, and we minimize the contact with the drapes and minimize handling. So these aren't rocket science. These aren't complicated approaches, but it's doing them consecutively, consistently, and we monitor complaints with this. So in Calgary, the 36 months before this bundle, the infection rate was about just under 8%. 48 months after the bundle, it's less than 1%. And we've had good feedback on this, and I think we're trying to now spread this across to other centers in Alberta and in Canada. The ventricular catheter placement is an issue. Traditional methods when landmarks are used, there as an anterior approach that some people prefer, a posterior approach. That's all landmark based. There's little evidence to support in adults which one is better. There is a trial that has a finished enrollment from HCRN, the pediatric group, trying to determine if there's a difference in children. Where the tip lands in the catheter, in the ventricle, there's no evidence to support whether in front of the foramen Monroe or back is of any difference. However, incorrect placement occurs about 1 to 20% of the time. This is an example of a catheter that was oriented well to the ventricle, but ended up in the sylvian fissure. So as part of this bundle, I looked at ventricular catheter placement. Well, could we do this better? I looked at ultrasound. I looked at using electromagnetic navigation, and decided on electromagnetic shunt placement because it was easily available and I could quickly adopt and use it, and I had familiarity with it. This is a study from Carolyn Hayhurst in 2010. It was a randomized trial. She showed that if you're using, and I'll show you what this is in a minute, but if you're using image guidance, poor catheter placement occurred in 0% in the Axiom group. And then if you really objectively look at it, 19% of the group using standard landmarks, and 3/4 of those 19% required shunt revision. So this is an example using the S7. You don't have to pin the patient. This is a receiver on the patient's head. This stylet goes down the ventricular catheter. I use this system to both pick the entry point and then to track it as we go in with the shunt. So there's the target, there's the entry point. There's a lot of variation in the location, shape of the ventricular system posteriorly. There's some difficulty in some of the older patients turning their head. So if you can move it a bit more laterally, that can help you get to easier placement. So this really is very, very useful, more useful than ultrasound at this point because you pick your entry point. Then we make a little curvilinear incision. We shave a bit of hair using clippers, not a razor. And we'll come back to the results of that in just a minute. The real problem in adults, very common problem, is peritoneal catheter obstruction. It probably accounts for 20 to 50% of shunt insertions in a year. In other words, 20 to 50% of shunt failures in the first year will be because of this. It's often obstruction by fat or omentum, or occasionally in long-term shunts by scarring or the occasional development of a pseudocyst. So there was this paper from Baltimore back in 2015 using laparoscopic technique to place the catheter through the falciform ligament. The falciform ligament connects the interabdominal wall to the liver to anchor it just behind the liver. And we took this idea, we've done a lot of modifications on it, and I'll show you this in just a sec, but I'll make this move. This is a short video segment. This is the catheter coming through the anterior abdominal wall. This is the falciform ligament. This is the left lobe of the liver. This is part of the falciform ligament. And we put the catheter through the falciform ligament. And I'll just click that video segment. And you can see the catheter then gets tucked behind the right lobe of the liver, and then we just trim it. This is an operation where you can't sort of pre-select catheter length. You have to trim it, and then we just remove the residual catheter. We did this prospectively, grading ventricular catheter placement using Carolyn Hayhurst grading system as grade 1, 2, or 3. 3's in the brain, 1's perfectly positioned in the ventricle. And then we looked at the positioning of the catheter in the abdomen just for verification. If we put it behind the liver, does it stay there? So is it perihepatic, free-floating, or malpositioned? So in this group, there were 115 patients before we started all these three aspects: infection prevention, image guidance for the ventricular catheter, and laparoscopic insertion assistance for the peritoneal catheter. So 115 versus 129 patients. We look down here, we had long follow-up. So the post-shout group, because this was a consecutive cohort series, the follow-up, while shorter than the other group, was still over 2 years. That's median follow-up. If we look at this group, the number of failures in the two groups, this is before the approach, dropped in half. Distal failures still remain a problem, and most of these are related to when the catheter pops out. But also infections drop down to 0% with the infection reduction package. So using the bundle to prevent shunt infection, you can have a very, very, very dramatic effect on shunt infection rates. This is something everybody should be considering using, no matter where you are, no matter how many shunts you do a year, and making sure that your compliance according to a protocol is very well set. This is a Kaplan-Meier curve looking at time to first shunt revision. This is the post group where we did the techniques. This is the population beforehand. So you can see at 1 year, we're looking at almost 60% shunt and failure rate. But shunts fail in the other group at a much slower rate and a much lower level. So almost a 50% difference in shunt failure. And this is a line curve looking at shunt failure after shunt insertion in 6-month blocks. And what you see here, this is the line here illustrates the major point where the chlorhexidine infection prevention bundle, Axiom, and laparoscopy were in place. So again, shunt failure rates in the first 6 months pretty high, and the shunt failure rates in the first 6 months dropped down substantially and continue to drop down. It doesn't mean, again, that shunts don't fail, but the failure rate early on is much, much lower, and overall down long-term, lower long-term. So again, to put this in perspective, just to illustrate that shunts are effective, and I'll show you that more in a minute with the iNPH population. Shunts can malfunction, and you can fix them, and effectiveness recovered. I'm not going to go through that in major detail, but that's an important principle. And most complications are minor, not life-threatening. And I think that we can all look at how we can improve this. And I've just tried to illustrate a couple of approaches that we found to be very effective. So I want to talk about overdrainage a little bit. This paper came out of Umeå in Sweden, Jan Malm's group, and they looked at overdrainage from their iNPH registry. It's a Swedish registry. And what they showed was that about 10%, look down here, 10% of the patients developed subdural hematomas. So this is a mixture of effusions and subdural hematomas. And it's a mixture of programmable valves and non-programmable valves. So lots of variables, but it shows us the relevance of overdrainage as an issue in patients. So what is overdrainage? So orthostatic headache is one aspect. Programmable valves can help a lot with this. Orthostatic hearing loss or hypacusis. I've seen this many times. And you can usually fix this by adjusting the shunt to make it more resistant to drainage. The trade-off with both of these is that you can potentially reduce shunt effectiveness by reducing the amount of drainage. In subdural effusions or chronic subdural hematomas, about 10 to 20%. If you look back at the old Dutch shunt trial, or if you look at the Sao Paulo trial comparing shunts and ETV with fixed pressure valves, it's about close to 20%. This is a subdural effusion. This is a patient that I saw very early in practice who had a fixed pressure valve with dramatic overdrainage and bilateral chronic subdural hematomas. So how you treat this is going to depend upon whether they have a fixed or programmable valve. So if you have a fixed valve, you have to usually tie off the shunt. You may have to drain the subdural or subdural effusion. If you have a programmable valve, you can often put the shunt up to the maximal setting. Different valves have different values for those settings. I think you have to be familiar with all those. I'm not going to go into a specific valve at this time, but getting it up to a higher level can be very helpful. Adding an anti-siphon or flow restrictor device or a gravitational device may be helpful to reduce this. There's a lot of work that needs to be done with this topic. Headache alone can happen with or without effusions or hematoma. What you have to do will depend on the size or type of effusion. I've had patients where a small effusion persists. They're not on anticoagulants, and that effusion at that shunt setting means they have better function, so I leave them at that level. And again, so that comes down to their clinical status. And then again, anticoagulants and antiplatelet agents, if they're on an anticoagulant or Plavix, or probably not so much with aspirin, but each of those agents can potentially increase the risk of having hematomas develop. I think we've improved this with programmable valves, and you can improve a lot of these symptoms, as I mentioned, but you have to do this balance of maximizing treatment effect with side effects. And we really need a lot more work looking at and developing programming strategies or protocols. I have one that we're testing. I'm not going to show that now just because of the complexity and the time it would take. It's worthy of actually an entire conversation, but I think we have to start looking at these things systematically. And just, I think everybody should have a backup shunt. One of the advantages of using laparoscopy is that it showed us when abdomens in the intra-abdominal space, a lot of scarring, and it looks like it's just not going to be a good environment to make a shunt function. And so a backup shunt, I decided to make VA shunts my backup shunt. Some people will use V-pleural shunts. There's literature on V-gallbladder shunts. VA shunts are used in a number of places quite extensively. The literature is not that extensive on VA shunts. So when I had to talk to people when I started redoing these and also to try and evolve the process. We decided to use transesophageal echocardiography. This is a TEE showing the right atrium and the catheter. So we quickly got past being able to position the catheter exactly where we want it. We had to do some tweaking with regards to the type of catheter. I now use an open tip catheter. Closed tip catheters with slits tend to clot at the end. There's issues of whether they should be on aspirin long term. And I think this is a study that needs to be done comparing VA shunts to VP shunts in a head-to-head fashion in a particular population. We published some of this initial experience using the transesophageal echocardiography. I think it's extremely relevant, and this is very preliminary. We've done probably about 60 patients. A lot of these have been revisions, but as a primary operation, it needs, again, probably a head-to-head study to compare the results. It's very effective, and if the abdomen is just not working, it's like that quote from Albert Einstein, just don't keep doing it until you hope it's eventually going to work. Move on to shunt version number 2. Treatment outcomes are poor is an additional concern. I think one has to understand the natural history in iNPH and in hydrocephalus. High pressure hydrocephalus people understand clearly that it's lethal, but iNPH is also lethal, has a high mortality and morbidity. One aspect of that is falls. So if one in 3 adults over the age of 50 will fall and develop a hip fracture, and 1 in 3 adults over the age 50 who falls and has a hip fracture dies within 12 months. Older adults have a 5 to 8 times risk of dying within the first 3 months of a hip fracture. Falls can result in hip fractures. They occur more common if you have gait or balance issues. They increase morbidity and mortality quite significantly. This is a brief paper from Karsten Mieszko's group, and it looks at the risks of mortality and risk of dementia in a normal pressure hydrocephalus population. They looked at a population of about 1,200 patients. They had a group of patients who had probable and possible iNPH. There weren't large groups, but the group with probable iNPH, these are people who really were considered to have iNPH, but they didn't have shunt treatment. They had a high death rate. And so their hazard ratio for death was 3.8. And the group with possible iNPH, they had ventricular megaly, but were followed, had an increased risk of developing dementia. So something to be considered. Arrested hydrocephalus is seldom arrested. That's usually a progressive disease. And if you have a diagnosis of iNPH, it's going to be progressive and result in morbidity or mortality. I think that all symptoms can improve. Gait is probably the most rapid to improve. Incontinence can improve. The ultimate degree of improvement is going to depend on how badly damaged the brain is, how much damage has hydrocephalus done. And you need to follow these patients long-term, and we have good evidence now about long-term effects. So what we do in our clinic is we use those protocols, we use objective measurements. for gait cognition and as much as possible for bladder. And we collect prospective data. For cognition, we have a core data set that includes cognitive gait and bladder data. We use the Montreal Cognitive Assessment. The MMSE is not as sensitive for hydrocephalus. We add in a symbol digits modality test. We look at depression because that can affect your cognitive assessment. We look at Lawton ADL, the bladder score. We have a video library of gait. We've added the timed up and go. We're looking now at quality of life, frailty, TENETI for balance and gait. We've added these things on in layers, and each of them adds more and more to help understand who's going to potentially get better, who should undergo a lumbar drain procedure. And just to show you a snapshot of our population, so this is looking at just under 300 patients who showed up in the clinic with suspected iNPH. So there's a slight male-female predominance, which I've seen in a number of other series and can't really explain. So of these, not everybody went on to, of these that went on to lumbar puncture and lumbar drain assessment. The lumbar drains, lumbar punctures, not quite as sensitive as a lumbar drain. So if they have a negative lumbar puncture, we'll often do a lumbar drain, and just under half of them were negative. But if you have a positive lumbar puncture, we'll go on to treatment, offering treatment with a shunt. And lumbar drains, people going for an external lumbar drain, about half of them end up being negative. This is just to summarize gait, cognitive, and cognitive with MoCA and SDMT, looking at median values. So gait velocity in an elderly person under 1 meter per second is abnormal, using that as a benchmark. If we look at, this is a summary of the patients who both went for ELD and lumbar puncture. Gait velocity was about 0.64 meters per second. After the lumbar puncture, about 0.84. After the lumbar drain, about 0.88. And then 3 to 6 months post-shunt, 1.05 meters per second. So significant improvement in gait. This is reliable change and clinically significant. MoCA usually doesn't get evaluated after a lumbar puncture, but when we evaluate it after a lumbar drain, the same with SDMT, not much change. But when you go 3 to 6 months out after surgery, there's a change of about 3 points on the MoCA and about 5 points on the SDMT. And that's, again, reliable change. So this is clinically significant and reliable change. But again, coming back to this article from, or editorial from Dr. Saper, we, in our research group, the AHCRN, has felt it really is necessary to change this mindset and to prove that shunting is beneficial or disprove it. And the best way to do that is with a placebo-controlled trial. So we have completed a pilot study called PENS. I'll briefly show you this just before we finish. It's a placebo-controlled effectiveness trial in iNPH, or PENS. The patients are blinded to whether they have a shunt put in that is either on or off, and it's using the Certus Plus valve, which has a virtual off setting. The assessors, people doing the pre-treatment assessment, and the patients are blinded to that setting, and they're randomized. We did the pilot with 18 patients. We've submitted this for presentation, and will be presented at the AANS meeting in August. We've also submitted an application to NIH for UO1, increasing the number of centers to 20 to do a larger population. The pilot was extremely beneficial in showing us how to navigate a very large and complex trial. This is just to illustrate the process for this trial. Patients get identified. They go through a standard assessment with lumbar drain or lumbar puncture. We're recording patients in our registry. We're going to offer them shunt surgery. We ask them if they're willing to participate in the study through an informed consent process. They are randomized off placebo or active shunt. At 4 months, they have another evaluation. So we have a group that effectively wasn't shunted for 4 months and a group that was shunted. Then both groups are turned on, and both groups still do not know what their setting is. They're followed out to 1 year, and at 1 year, they're told what their setting was. So we have a 4-month period with no shunt function in one group, and a 4-month period, or an 8-month period rather, with shunt function in both groups. So the preliminary data is encouraging, but underpowered as we expected. And we're very hopeful that being able to do the larger study will help to complete this. So that's basically the overview of how we approach the assessment treatment. And hopefully by answering these 3 questions, I've been able to sort of come through some of the concerns that you may have had or may have about shunt surgery, with a brief mention about endoscopic third ventriculostomy. Our Hydrocephalus Society has a meeting this year. It's virtual because of COVID in September. And then in 2022, it will be held in Gothenburg, Sweden. Thank you.
Thank you very much for this enlightening lecture, Dr. Hamilton. We have a few questions from the public. The first question is regarding outcomes in idiopathic normal pressure hydrocephalus. What is your opinion regarding lumboperitoneal versus ventriculoperitoneal shunts?
That's a good question. So as I mentioned, there is no head-to-head study that compares different types of shunts. Each shunt has its constraints. So somebody with a lot of abdominal problems, not a good candidate for a VP shunt or a lumboperitoneal shunt. Somebody with a lot of spinal problems, not a good candidate for a lumboperitoneal shunt. I think that there's good work from Japan from a number of centers, and there's a couple of good randomized papers looking at this population using lumboperitoneal shunts. So I think lumboperitoneal shunts have a definite role. They deal with some patient concerns that may exist about doing a cranial operation. I think what I've tried to show you is that cranial operations carry low risk in this group. But I think it's important that everybody have a shunt that they're really comfortable with. Everybody should have a backup shunt that they can do if the situation doesn't allow you to do the one you like. I know there are some people who do VA shunts primarily all the time. So each of these has value. Someday we will hopefully have some better idea how to select people beyond what I just mentioned.
Okay, thank you. Second question is, in cases of obstructed hydrocephalus secondary to posterior fossa metastasis, in which patients would you recommend ventricular shunt over endoscopic third ventriculostomy?
So that's a complex problem because it's going to really depend on a number of things. I have used, so if the patient has a MET that's selectively blocking the CSF pathway versus the fourth ventricle or the bottom part of the aqueduct, or down the fourth ventricle, that's usually a very good patient as long as the anatomy will allow you. That's a good patient to do a third ventriculostomy on. It's lower morbidity, it's quicker, you don't have to worry about overdrainage issues, you don't have to worry about a lot of the dynamic issues. People who have complete obstruction of their ventricular system are also, especially with tumors and bleeds, are also at a higher risk for developing this disorder called acute low pressure hydrocephalus. And we published some literature on this and an algorithm to try and navigate people through it. The best way to navigate through it is to avoid it. And the group that has the highest risk of it is a group with clear obstruction. And ETV, if you can do it, is a much better choice in that group than shunts. If you have big METs in the posterior fossa, I mean, it comes back to removal of the METs. So treating the underlying obstruction. If somebody has a very short lifespan and a simple obstruction lesion, such as the pineal gland or in the posterior fossa, then ETV is a very good palliative procedure for that patient. And less, I think, of an issue for them post-treatment than a shunt requires less rigorous follow-up in terms of shunt risks. So again, complex problem.
Yes, for sure. But thank you for your answer. Another question is, what is your preferred shunt system to minimize the siphon effect?
So preferred is different from best, because I can't tell you what, so each of us has in our healthcare systems limitations on the number of valve choices we may have. I know neurosurgeons who don't even have the option of programmable valves. So if I had to list the priorities, one would be I push for as much as possible programmable valves. They do get, programmable valves are to some degree sort of, if anybody who's played Monopoly, a get out of jail free card. You rather than having to do reoperations on patients, which I had to do early in my practice, tying off shunts, you can turn their valves up to maximum. And for a good percentage of those patients, that is effective. Now then, when you try and look at the other things that you can do in a valve, there's siphon guards, there's the, Medtronic has the Delta chamber, which is an anti-siphon device. There's the gravitational devices. Each of these has their own pluses and negatives. Cost is, varies quite a bit. Bulkiness, position vary. At this point, I tend to use the Certus Plus valve because it has the virtual off. And for those that don't know the settings, the virtual off setting is about 450 to 550 millimeters of water. So if you think of a programmable Hakim valve or a Strata valve, the upper limit when you go to their 2.5 or which is somewhere getting close to 200 millimeters of water, or a Hakim valve, you're at 200 millimeters of water. That's the upper limit. So the Certus gives you a significant increment above that, the Certus Plus. So it's been very useful. I haven't had as much experience with the Aesculap valves, partly because of availability and how our system allows us to select what valves we can use. So the combination of a valve that's programmable with some type of flow restrictor, because we didn't get into siphoning, and then again, that's another whole talk as part of overdrainage. Very complex. I think the number one thing I look for in the post-op period in patients is overdrainage. So I currently, some people will scan their patients at a month looking for catheter placement, confirm you're in the right spot. I do that, but I also scan people, CT scan at 1 month and 3 months. That's the highest risk period for overdrainage. And I want to be able to immediately intervene and turn that valve up or off. We have a paradigm or a protocol we use to manage those patients. You also have to look at the issue of anticoagulation, as I mentioned, because that's extremely important. Can you stop the anticoagulants for a period of that first month when the risk is the highest? If they really need to be on it, then you really need to be very, paying a lot of attention to that particular issue in that patient.
Thank you. And in line with that topic, siphoning, we have another question here. How do you see the role of siphoning at present and in the future in hydrocephalus treatment?
So siphoning is, our current valve, most common valves that are used, and there's some other nuanced valves out there that don't use the differential pressure model. Our current valve selection is really all based on the same principle. We're going one company or another, different designs, different mechanisms, but the idea is that the inlet pressure is different from the outlet pressure, and at that particular setting, when the inlet pressure goes high, it drains. And then we built into that concept of differential pressure is a valve that when you stand up, the length of catheter you have adds to that differential pressure and you siphon. So that's really nice on a bench. I think in the human body, it becomes much more difficult to predict. There are a number of strategies people use in the OR. People will look at their opening pressure and try and select a valve setting above or below that. I think that people have done it during the OR when they first put the ventricular catheter in. And they figured the idea that if using some sort of paradigm where you select a valve setting that's a little bit more resistant, they'll drain, still effectively drain, but won't siphon. All of these systems, all of these paradigms, I think the most important thing is that somebody's using something that they're paying attention to. It comes back to bundles for infection prevention. There are things that are really important that we'll find out eventually that you should be doing, but really pay attention to it. And None of these, though, has been evaluated in any significant way. None of them have been evaluated in a head-to-head fashion. What you're selecting your valve, as we've already discussed, is extremely important. The type of thinking about a siphon, anti-siphon device, or some way to reduce siphoning is important. VA shunts do not eliminate siphoning. They even though people think of VA shunts often as eliminating siphoning, I can show you patients who have VA shunts who have siphoned, because maybe they siphon less. Nobody's actually looked at that. That's speculative, but they still siphon. Tall people with long peritoneal catheters may siphon more. That again has not been sorted out. LP shunts have a different set of issues, and so it's harder to talk about the siphoning effects in LP shunts. So again, this is an area that it requires a lot of work. The ideal valve, if we had it, would be, so when I put a lumbar drain into people, I do 10 cc's an hour or 5 cc's an hour. I adjust the drainage to whether they have headaches or not. And the ideal valve where I could set flow in cc's per hour. That doesn't exist in any small, usable, or cheap, inexpensive product. It's just not out there. That would be what ideally I think we should all have.
Okay, thank you. Another question is, do Evans index and other ventricular serial measurements in a CT give any help in fine-tuning of a G valve?
Fine-tuning in what? Sorry, I missed that last part.
Fine-tuning of G valves.
Gravitational valves?
I think so, yeah.
So I would like to emphasize that I brought up Evans index as simply important that we have some way of communicating. So if I tell somebody that they've got an Evans index of 0.45, that's different from an Evans index of 0.3, because I would think that overdrainage issues in the 0.45 would be probably higher than in the 0.3. That's a viewpoint, not something that's set in stone. But I think we see the reasons I use ETV in the middle-aged, unrecognized hydrocephalus group with obstructive hydro is that they tend to be a high-risk group for overdrainage. And the ETV it pushes that off as a very, very minor problem by avoiding the shunt. So how do you use Evans index? One is to communicate. Two is to identify potential risks of overdrainage. So if I have somebody, and again, this has not been proven, but my current paradigm for selecting valve settings for patients, whatever valve I'm using, is based partially on their Evans index. It's based on whether they had a headache when they had their lumbar puncture or lumbar drain. Most iNPH patients do not have headache. If they do, that worries me. So even then I just had to pick things and then put them together in a bundle to assess them. Did they develop any effusions with their drainage? That's very rare. You don't usually see that. And so we use, and whether they're on anticoagulants. So all of those things with Evans index as a starting point, I use to try and guide, but I don't think that the answer is set in stone at this point. I've been using a programming protocol for about a little over 2.5 years. And it's going to take a fairly long time to determine whether there's utility with it. So one thing to consider is if you have somebody with really big ventricles, use a valve with a higher setting. It's easier to go down if they need clinical effect than it is to manage a subdural and go up. And that's the basic underlying concept behind what I've done with my protocol that I'm using, where you have big ventricles. I'll start at a higher setting, and then we can titrate that down. And each time we titrate it down, we're starting to look for overdrainage again. I hope that answers the question.
Thank you. What are the most common ventriculoperitoneal shunt-associated infections and how to prevent them?
Sorry, could you say that again? I missed the first part, please.
What are the most common ventriculoperitoneal shunt-associated infections and how to prevent them?
So I can approach that a number of different ways. What are the most common organisms, or what are the most common risk factors? So I think risk factors, number one is not having I think this is really important. You have to have a protocol. We approach surgery, neurosurgery, like it's a process. We go in to do a spine procedure or an aneurysm or a brain tumor. We go through it step 1, 2, 3, 4, and we've in our minds we've thought about all of the different possible pathways that might diverge and might have to go down a different way. I think before you start the operation, during a shunt operation, you have to have a series of steps, similar way processes that reduce those things that are high risk for shunt. So the most common organisms you get are going to depend on your hospital environment. They're almost always skin organisms. If you had a patient who was in an ICU with a ventricular drain, you start getting into the risk of other organisms, immunosuppressed patients, other organisms, gram negatives, and the worst probably to get is somebody with a fungal infection. But the most common you're going to see is Propionibacterium, Staph epi, Staph aureus. Now, if that's the highest risk for shunt infection is at the time of surgery, it is the contact with the skin. So everything is done to prep the skin, and I think there is a real difference between chlorhexidine, alcohol, and betadine, providine. And in our preliminary work, the infection rate dropped by putting a bundle in place. Adding chlorhexidine, alcohol significantly dropped it. So that's one thing. Drying the solution, another. The idea that you can contaminate your gloves very easily during draping, and that gloves get holes in them. There's old literature from sick kids in Toronto showing that if you take gloves off of people after a surgery, a huge percentage of them have micro holes. So again, skin contact, a barrier on the skin to minimize contact. That's why we use this betadine impregnated stuff to hold all the drapes down. Not necessarily something that's supposed to reduce the risk of infection because of the betadine. It's because it holds the drapes in place and keeps your contact with the skin down to a minimum. Some people will line the edges of their incisions with patties. Some people will soak those in a dilute solution of chlorhexidine. But so it's minimizing contact with the skin edges with the skin, making sure that everybody who touches the shunt has clean gloves, taking the shunt out just as you're going to use it. All of those things reduce the risk of infection. People think that shunt revisions have a higher risk. We do, most of our shunt revisions in adults are distal catheters. A lot of them are done intraperitoneally just with the laparoscope going in and dealing with it. Our infection rate in revisions is almost 0. So really think about, again, the processes. What are you doing in the OR that is going to increase the risk of infection? And all those things I talked about, if you mitigate those risks, your infection rate will plummet. Keeping traffic down in the OR is just simple common sense. ORs have air filters, and air filters have capacity. Everybody's more familiar with air filters now since COVID happened, but it's an important concept to look at as well.
Okay, thank you very much. How long should one wait to document or to see a neurologic improvement after a lumbar puncture drainage in a normal pressure hydrocephalus patient?
That's a good question, and the reason that many people ask it is because there's such variability in what's reported. So there was a time where one of the main authors of the initial 2005 guidelines was working on a concept of take 30 cc's off and evaluate them 30 minutes later. So I think that is not a good way, unfortunately, because I think we miss a lot of people. You pick up some people, but you miss a lot of people. So to increase what you want to increase is sensitivity and specificity. What most people, first of all, there's a couple of nuances. One is if you're going to do a lumbar puncture, you use a large needle. So no 25 or 26 needle. You use a 18 or 20 needle. You take off, I try and take off 40 to 50 cc's. I don't let the patient lie down for the next half hour. They get up right away. iNPH patients do not get headaches. If they were on aspirin or anticoagulants, we stop that. Aspirin you can probably get away with, but we, as a rule, stop anything that's antiplatelet or anticoagulant. I then send them out, usually for lunch, go out with their family, they come back. Everybody should have their their baseline assessments done beforehand. So they've already got their cognitive, their gait done. They come back. We don't, for a lumbar puncture, do their cognitive, we do their gait. So that's usually 2 to 3 hours later. There are places where they will bring people back later than that. We also, if they had a positive response, we have a discussion about shunt surgery as an option rather. If they had a negative response, we usually do our LPs on Friday. We communicate with them on Monday. And if they think they have had a better response, we bring them back and reassess their gait. So there is a good literature on delayed assessment. I think if you freeze it at one point in time only, you're going to miss patients. And you're going to be potentially bringing that patient back for a bigger, longer procedure when they may have actually had the result. So Richard Edwards is a neurosurgeon in Bristol, UK. He has a diary system he sends home with the patients, and he looks at the diary as an additional adjunct. I like to see reliable change in their gait. And the Tonetti balance test is extremely important because that really helps a lot now. We've added that to our selection process. When you look at how you select people, it's not just their gait velocity or their MoCA. It's often a lot of things that you can't capture. There's a Gestalt view of things. We look at the video very carefully before and after. We've added the tug because that adds an additional aspect of getting up out of a chair. So a lot of different features to evaluate, and the same for the lumbar drains. If we do a lumbar drain and they get, say, removed on a Friday and we assess them and they didn't have a positive response, we do a follow-up call on Monday with also instructions that any time, if they should feel that there's an improvement the next 1 to 2 weeks, they call us. Because there is this delayed response group. It's not big, but it's important to recognize.
Thank you very much. It is now known that idiopathic normal pressure hydrocephalus patients have another comorbidities, for example, hypertension or heart disease, that may condition a decrease in venous outflow and hence condition a decrease in reabsorption of CSF that would explain the appearance of this pathology, idiopathic normal pressure hydrocephalus. Would you suggest a screening process for these patients in order to predict the appearance of iNPH?
Boy, that's a big open-ended type of question. So lots of issues there we could sort of discuss. I think first of all, comorbidities in the iNPH population are high. If we start off by simply using the age of 60 as a cutoff point to be considered as possible for iNPH, you just know that cardiac and coronary artery disease, hypertension, stroke, all those things go up in as comorbidities. And the work that we published from our network shows that that's the case. Comorbidities are quite high. We have a paper that we're preparing where we see that and specifically looking at the iNPH population, that comorbidities are high. I think that the comorbidities, while they may predict and then may have some effect on what people refer to as the lymphatics, they may be somehow related, and they probably are because there's a lot of parallels. Starting with a group that have comorbidities and looking for iNPH is probably not the way to go. It would make more sense to, if you have iNPH, somebody has cognitive gait balance issues and ventriculomegaly, and they don't have another obvious comorbidity such as Alzheimer's or frontotemporal dementia, some other neurodegenerative process that explains their problems, that you look at the comorbidities as elements of risk for treatment, and that rather than looking at the comorbidities as a way to identify people with iNPH. So, and comorbidities do not preclude you necessarily from having surgery put forward as an option. Comorbidities can be mitigated in many circumstances. I mentioned anticoagulants and antiplatelet agents. You have to look at those. But the average age of this patient population is about 78 to 82. So that's an older population group, and outcomes can be quite good in this group as long as you pay attention to the details.
Okay, thank you. Well, we have a lot of questions here, and I wish we could solve them all. Let's try another one. Have you encountered shunt failure because of factory defects?
Shunt failure from factory defects. So when you look at the number of shunts that where you have a catheter that has a fracture that develops, or a valve that fractures, it's a small number of patients. It becomes very difficult to separate out whether it was a technical problem at the time of insertion. Did somebody handle the shunt material with something sharp and put a slit it into a hole in it that could then spread? It's not that common. I would think that in our study it was well under 5%. It's probably the least common cause. Before we started the infection protocol, infection was probably higher cause of shunt failure than shunt malfunction from an appliance point of view. But now shunt infection is very, very low. So it's the second most common thing, but still very, very small. So if you have a malfunction valve, you should return it to the manufacturer and ask them to look at it to see if there's anything relating to quality. And we do that routinely if we do have a problem.
Thank you. Is it necessary to use navigated placement of the shunt in every case?
So I think that it's extremely valuable. Is it necessary? I mean, there was an era where people clipped aneurysms without microscopes. Most people would feel that you can do that, but it's not necessarily the best way to do that. Many places used to use. I trained in an era where we did microdiscectomies, or we did discectomies. We didn't do microdiscectomies, and now people do all kinds of different variations on lumbar discectomies, but with imaging. I think the same thing applies to our mindset on this particular issue. People have been putting in particular catheters for ages. The problem is that the catheter failure rate and misplacement rate is underestimated and underreported. And it's actually higher than people think. I didn't go into that in detail, but from the paper that we've got coming out of Journal of Surgery, we graded all of the patients before and after using the image guidance. And it mimics very much what Carolyn Hayer's paper showed. The number of missed catheter placements, in other words, in the brain, 0. The number of catheters with good placement, with a high score, really, really high. Very few catheters where there was intermediate placement. So I think you can significantly improve the outcomes, decrease the risk of requiring to go back for another operation. In addition, I think that there's probably a beneficial effect of having a good positioned ventricular catheter, a well-positioned catheter, and the effect on flow. iNPH in the peritoneum and overall shunt function. iNPH patients do not have high pressure flow. They're often, if you do shunt flow studies, you'll see that many of them, when they're flat, they don't flow. They only flow when they're sitting up and they're using some of their siphoning. So having a well-positioned ventricular catheter, I think, just augments that flow aspect of it. That's my speculation. We had some very preliminary data from that's in the paper that suggests this, but it's just hard to prove because of the numbers. So while we're at a point, I think, of transition here, and it's whether we can look to this as being an operation that requires more frequent use of technology to improve the outcomes in patients. And I think that hopefully that people will embrace this as time goes on because of the very, very strong benefits.
Thank you. And the last question, any recommendations to avoid intermittent shunt blockage in neurocystic sarcosis?
Oh, so a lot of patients with neurocystic psychosis, they often have an obstructive element to their hydrocephalus. It's quite variable. I haven't had a huge experience with it because it's not as common in our area. But the shunts, the people that I have seen tend to have small ventricles, small ventricular caliber when shunted. Very much like what you see in children who've been shunted all their life. And so proximal catheter failure is more common in that group. Having programmable valves can be of benefit. When you first treat, and this is speculative because I can't prove this, but if you're able to keep the ventricular caliber a little bit big and not have it disappear, the ventricles disappear, you probably have less risk of proximal catheter failure. The issue of programmable valves and reducing overdrainage in children was sort of displaced quite a long time ago by a randomized shunt study. In adults, it's very different, and I think programmable valves do have a lot of value, and that should be one of your goals. You're looking at using some sort of anti-siphon device, program high and bring them down. If you keep the ventricles a little bigger, don't let them become slits that you see sometimes in children who've got, you can see a catheter and you can't even see the ventricle, and you're less likely to get proximal catheter failure. Distal catheter failures are the same issues that we discussed for the iNPH patients. Laparoscopic placement will be of significant benefit if you can position it properly in the abdomen.
Okay, thank you. Well, we have a lot of people posing questions, but we don't have a lot of time. So I'd like to thank you again, Dr. Hamilton. This has been a wonderful lecture and wonderful Q&A session. And we're really grateful and honored for your participation in the 2021 at WBNC.
And thank you very much for having me. And to the people that were asking questions or just listening, thank you very much for your engagement. Much appreciated.
Yeah, thank you. For all the audience, keep in mind this lecture will be available on our website starting next week. Thanks to all the audience for accompanying us during this third and last day of the 2021 at WBNC. Please stay connected for the closure and last words by Dr. Javier Saavedra, Scientific Director of the Center for Research and Training in Neurosurgery. Thank you very much.
Thanks to all the audience who followed our broadcast during these 3 days of the 2021 International Web-Based Neurosurgery Congress. The 2021 WBNC, developed by the Center of Research and Training in Neurosurgery, proudly hosted 31 lectures from some of the world's most renowned neurosurgeons, and going through some of the most relevant topics in neurosurgery. As we put every effort to bring a significant experience to the participants and the speakers, we added 2 academic modalities, the Spine Pre-Congress course and the e-poster video presentations. The former, developed in partnership with the Seattle Science Foundation, was designed to understand advanced lateral approaches to the spine and sagittal balance of the spine. The latter was designed for participants wanting to share their academic and research experiences. We believe we were able to meet our goal to connect the neurosurgical community around the globe, and that it's a great achievement. We will also like to highlight the most popular e-poster during the 2021 IWBNC. First, Dr. Felipe Gutierrez Pineda from University of Antioquia, Colombia, with his e-poster titled Technical Skills, the Neurosurgery Resident Experiences in Sylvian Fissure Split and Microsurgical Aneurysm Clipping, a comparison between pterional and mini-pterional craniotomies. Second, Dr. Miriam Nasor from Trauma and Burn Center in Tunisia, with her e-poster titled Cerebellar Liponeurocytoma, Case Report and Review of Literature. Congratulations to both of them. Once again, thanks to all participants and attendees. This whole event will not have any sense without you. Keep connected to CIEN and expect more virtual education to come. See you in 2 years at the 2023 IWBNC. Thank you very much.